Okay, good evening, everyone. Thank you, Dr. Racarla, for that very kind introduction. Thank you to the Takeda group, particularly to Dr. Ariel and Dr. Joy for inviting me, as well as to the PSG to be part of this very important webinar, along with our distinguished speakers, Dr. Soriano, Dr. Garcia, and Dr. Tablante. This week on May 19 is World IBD Day. So we join hands with our IBD experts, doctors, IBD patients, and the IBD community in joining hands to fight against Crohn's disease and ulcerative colitis. The webinar is entitled Trending Topics in IBD, and I was tasked to talk on ulcerative colitis. Due to the limited time, what I did was I conceptualized a lecture in which we will be trying to answer some of the common questions that we encounter in clinical practice. Okay, these are my disclosures. Can you see my slide?
Yes, we can.
Can you see it or no?
Yes, doctor, we can see it.
And is it moving?
We are on the disclosure slide.
Okay, good, good. Thank you, Dr. Carla. This is the disclaimer slide. Okay, this would be the lecture outline for my lecture. First, we'll be giving an introduction on ulcerative colitis. Then we will have 4 questions that we will try to answer. First is, how do we classify the severity of ulcerative colitis? Second, how to optimize the use of mesalazine in mild to moderate ulcerative colitis. Number 3, when to start biologic treatment in ulcerative colitis. Number 4, when to manage in patients with acute severe ulcerative colitis. So ulcerative colitis is characterized by recurrent episodes of inflammation limited to the mucosal layer of the colon. Despite obvious similarities between ulcerative colitis and Crohn's disease, they are actually distinct entities. So if you have a patient with small bowel involvement, that's no longer ulcerative colitis. It is most likely Crohn's disease. However, if you have a patient with exclusive large bowel involvement, it could be ulcerative colitis or it could be Crohn's disease. And the term indeterminate colitis is reserved for a minority of patients when it is not possible to clearly differentiate between ulcerative colitis and Crohn's disease. What are the unique features of ulcerative colitis? Ulcerative colitis is characterized by the continuous inflammation of only colonic mucosa. There is usually a clear distinction or transition between the inflamed colon and the normal appearing colon. There is also around 90% of cases of ulcerative colitis involves the rectum. And if untreated, there is actually progression of the colitis, eventually involving pancolitis. So these are the different patterns of disease that we can find in our patients. The most common is actually this one. There is initial high activity, followed by either a remission or mild symptoms. The next would be the chronic relapsing course of patients, which is found in around 30% of patients. So you will have flares followed by remission, and then flares and remission. And the chronic continuous symptoms are usually found in less than 10% of the patients. And the rarest type is having a later high activity at the end of the disease. Okay, ulcerative colitis is a progressive disease. And around 15% of UC patients experience proximal disease extension over 9 years. So we need to find out, we need to prognosticate these patients who will eventually develop proximal disease extensions. And gladly, there are actually clinical factors that would help us. This include if the patient had a delay in diagnosis of more than 6 months, a family history of IBD, young age at diagnosis, disease severity, the need for steroids at diagnosis, poor response to therapy, which is defined as more than 3 relapses per year, and a concurrent primary sclerosing cholangitis. Colectomy is also a bad outcome in ulcerative colitis, and there are factors that predict colectomy. So this include the disease extent, young age, male gender, an elevated CRP, and ESR. Among these 4 factors, disease extent consistently influences the risk of colectomy. So if you have a patient with extensive colitis, the 10-year cumulative risk is around 19%. Left-sided colitis is around 8%. And ulcerative proctitis has the lowest 10-year cumulative risk, which is only 5%. So first clinical question we want to answer. Hopefully, we will learn from this, since these are the common questions we see in clinical practice. How do we classify the severity of ulcerative colitis? The severity of disease is important in the clinical management and also can predict long-term outcomes in ulcerative colitis. The more common ones that are being used are the Montreal classification of extent and severity. You have the Mayo Clinic score or disease activity index. You have the ulcerative colitis endoscopic index of severity, and the TrueLove and Wheat severity index. So let's kind of go one by one. So this slide should be familiar for all of us who have been attending the IBD club sessions. This is the Montreal classification of extent and severity. So it defines the extent and the severity. So E1 is ulcerative proctitis, so it's limited to the rectum. E2 is left-sided ulcerative colitis, so it is limited to a proportion of the colorectal area distal to the splenic flexure. And E3 is extensive or pancolitis, in which the colitis extends proximally to the splenic flexure. How about the severity? So they define S0 as clinical remission or asymptomatic. S1 is mild, less than 4 stools per day with or without blood, absence of systemic illness, and normal inflammatory markers. S2 is considered moderate. So there are more than 4 stools per day, but there are no signs of systemic toxicity. And S3 is severe if there are at least 6 bloody bowel movements, there is tachycardia, there's fever, there's anemia, and the ESR is greater than 30. How about the Mayo score? For those of you who read the clinical trials, this is the most common index of severity that clinical trials use. It is also known as the Mayo Clinic score or disease activity index, and it has 4 components: stool frequency, rectal bleeding, physician global assessment, and mucosal appearance. Sometimes if you have a patient that you are seeing and there's no recent endoscopy, you only have 3 of the 4 components, and we call that the partial Mayo score. But if you end up admitting the patient or doing an endoscopy, you could complete the Mayo scoring system. So a Mayo Clinic score of 6 to 12 with an endoscopic subscore of 2 or 3 is considered moderate to severe disease. Okay, so these are pictures of the Mayo endoscopic subscore. So 0 is actually a normal mucosa. 1, you see some erythema, decreased vascular pattern, and malfriability. With 2, there is marked erythema, absent vascular pattern, friability, and you start seeing erosions. And a Mayo score of 3 has spontaneous bleeding and ulcerations. There is also the ulcerative colitis endoscopic index of severity, or UCEIS. This is actually more complicated because it actually goes to speech specific component of endoscopy findings. So you have vascular pattern, bleeding, and erosion. So if you total this, actually this will be around 8, that's 6 plus 2, 8, compared to the Mayo score, which is much easier, is just 0 to 3. And there is actually an extended ulcerative colitis index of severity, and I think it's up to 11 points. Okay, and we have the True Love and Wit Severity Index. And what is actually interesting, this was actually formulated way back in 1955 by Dr. Truelove and Weitz, and it has been modified with time. And the good thing about this one is it combines clinical findings, physical examination findings, and also lab findings. So you have a mild case if your bloody stools are less than 4, you're not tachycardic, there's no fever, there's no anemia, your ESR is less than 20, as CRP is normal, you considered a person having severe ulcerative colitis if they have 6 bloody stools per day, they are tachycardic, they have fever, they have anemia, they have an elevated ESR and CRP, and in between is considered moderate. So our next question is, how do we optimize mesalazine treatment for mild to moderate ulcerative colitis patients? So mesalazine, or mesalamine, or also known as 5-ASA. In patients with inflammatory bowel disease, there is increased mucosal production of arachidonic acid metabolites like prostaglandins and leukotrienes. Mesalamine as a medication decreases inflammation by inhibiting the enzymes cyclooxygenase and lipooxygenase in the colon, and this in turn blocks the production of prostaglandins and leukotrienes, inhibiting neutrophil chemotaxis. Mesalazine is only active intraluminally, so it is not absorbed. So how do we use mesalazine in the treatment of ulcerative colitis? It is available in suppositories. It could be given as foams. It could be given as enemas or oral. Okay, this I got from the AGA technical review on the management of mild to moderate ulcerative colitis. Remember, mesalazine is only used for mild to moderate and not for moderate to severe. So the key messages here are all types of doses, whether the low dose, which is less than 2 grams, standard dose is 2 to 3 grams, and high dose is less than 3 grams, are more effective than placebo, but as comparing to placebo. But what you have to remember is the high, which is greater than 3 grams, and the standard dose, which is 2 to 3 grams, is more effective than low dose mesalamine for inducing and maintaining remission in patients with mild to moderate UC. So it does not make sense to actually use less than 2 grams if we're trying to induce remission, okay? And also in a subset of patients, high dose mesalamine may have a small benefit over standard dose mesalamine for induction and maintaining of remission, okay? So one of the interesting questions that I found in the AGA technical review is, in adults with extensive mild to moderate UC, is combined oral and rectal 5-ASA superior to oral 5-aminosalicylate therapy for induction and maintenance of remission? So there is a study done by PINS, and it's a European multi-center double-blind randomized control, and it aimed to investigate if adding a mesalazine enema to oral mesalazine has additional benefit for patients with extensive mild to moderate active UC. So this is their protocol. So you have the mesalazine 4 grams plus a mesalazine enema. versus mesalazine only, but they gave a placebo enema, okay? And these were their results. In mild to moderate extensive UC, the addition of a mesalazine enema at 1 gram per day for the first 4 weeks of an 8-week course was more effective than oral mesalazine alone. And the other thing is rectal bleeding stopped in significantly more patients in the active group compared to the placebo. So there is the topical effect of the enema here. So the key message here is in patients with extensive mild to moderate UC, combined oral and rectal 5-ASA therapy is probably more effective than oral 5-ASA therapy alone for induction of remission and maybe for effective for maintenance of remission. Okay, so even ECHO, so this is the European Crohn's and Colitis Organization, they actually included this in their recommendations that if you have left-sided colitis and extensive UC, they should be treated with 5-ASA enemas plus oral mesalazine for induction of remission. Okay. This other question is, in patients with mild to moderate UC treated with oral mesalamine, is once a day comparable to multiple times per day administration of mesalazine? So there was actually a trial on this. So this was the MOTUS clinical study, and it's also another European multi-center study in which they compared mesalazine that was actually given once a day, but they included pentasa enema here, versus mesalazine given twice a day, but equivalent doses. And their finding was mesalazine 4 grams OD was non-inferior to mesalazine 2 grams twice a day in achieving endoscopic and clinical remission at week 8. So basically, the key message here is in patients with mild to moderate UC treated with oral mesalamine, there is probably no difference between equivalent doses of mesalazine administered either once a day or multiple times for inducing and maintaining remission. And this is actually good for our patients because it improves compliance. Okay, the next question is, this is probably the more exciting part, is when do we start biologic therapy in ulcerative colitis? Okay, these are the current medications for ulcerative colitis. You have the 5-ASA, the corticosteroids, and the immunomodulators. So these three are classified as conventional therapy. And then you have the biologics, and now we also have small molecules. What are biologic agents? Biologic agents is a class of drug produced by living organisms such as bacteria or mammalian cells in culture. It consists of large and complex molecules and are often protein-based. They are produced through biotechnology in a living system such as a microorganism, plant cell, or animal cell. It provides a more targeted approach to reducing inflammation in the form of monoclonal antibodies against tumor necrosis factor, interleukins, and anti-integrins. The problem is these drugs are very expensive. So there are constraints in making them widely accessible in Asia. And this was noted that a rise in the biologics coincided with the decline in the prevalence of colectomies, which is obviously a bad outcome in UC. However, when they did a closer observation, most of this decline was actually attributed to the use of infliximab, which was the first biologic we have. So to answer the question, when do we start biologic treatment in a patient with ulcerative colitis, we heed to the advice of the Asian Organization Asian Organization and APAGI for practice recommendations, in which Professor Jose Soliano is part of that group. And they said biologic therapy is recommended for treatment of moderate to severe ulcerative colitis if conventional therapy fail. So what does that mean? So biologic should be initiated in patients not responding to conventional therapy, which is usually defined as a disease that is refractory or intolerant to adequate doses of immunosuppressive therapy. Number two, if they exhibit corticosteroid dependence. So that means they have recurrence of symptoms on corticosteroid tapering. Usually when you reduce your prednisone to 10 milligrams or less, they started having recurrence of their symptoms. And every time you taper them to that dose, their symptoms flare up. So that is corticosteroid dependence. And corticosteroid refractory disease means that they don't even respond to steroids. Okay, so what are the different types of advanced treatment? So they could actually be classified whether are they cytokine targeted or they are anti-lymphocyte trafficking. So kind of just going over this list quickly. So the TNF antagonist, it is the tumor necrosis factor interacts with its receptors on a wide variety of cell types to mediate their biologic functions. So you have an antagonist, and we have infliximab, adalimumab, and golimumab in the market. We also have IL-12 and IL-23 inhibitors, and we have ustekinumab here. And then we have the JAK, the Janus kinase inhibitors, which I will discuss later on. The example is the tofacitinib. For anti-integrin, this is where we have vedolizumab. They are gut-selective anti-lymphocyte trafficking agents, and they mitigate the trafficking of T lymphocytes by blocking the activated lymphocyte surface receptors. And this is a new one, the sphingosine 1P receptor modulation, and is already approved in the US for ulcerative colitis.